Namaste Bitya, Hamesha Khush Raho Bitya. A very good morning to you all. Myself, JV'n Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine at Faculty of Homeopathic Science in JAYOTI Vidyapeeth Women's University, Jain. In today's lecture, we are going to discuss about the genetic disorders, the Turner's syndrome. Turner's syndrome is also known as the gonadal dysgenesis or 45X. Turner's syndrome affects approximately 1 in 2,500 females. The syndrome is classically associated with 45XO karyotype, but other cytogenic abnormalities may also be responsible, including the mosaic form, example 46XO or 46XX, or 45XO or 46XY, and partial deletion of an X chromosome. The clinical features of Turner syndrome results from hepatoinsufficiency of multiple X chromosomal genes. Turner syndrome is characterized by bilateral streak gonads, primary amenorrhea, short stature, multiple congenital anomalies in phenotypic females. So these are the clinical features of Turner syndrome, that is 45XO, which consist of short stature, fish-like mouth, high arched palate, autoimmune thyroid disease in 20% of the cases, coarctation of the aorta, bicuspid aortic valve, aortic root dilatation, coronary artery disease, hypertension, abnormal liver function test, that is 30 to 80%, streak gonads, gonadoblastoma. Psychological problems, which includes impaired visuospatial processing, reduced IQ, that is ring chromosome X, low set ears, sensorineural conduction hearing loss, webbing of the neck, that is 25 to 40%, widely spaced nipples, shield chest, wide carrying angle of the elbows, type 2 diabetes or impaired glucose tolerance test in 10 to 30% cases, inflammatory bowel disease in 0.2 to 0.3% cases, horseshoe kidney, and the other renal or collecting system abnormalities. Reduced bone mineral density, and there is lymphedema of the hands and feet in 30% of the cases. Clinical features include the genital tract and the external genitalia in Turner syndrome are female in character. The ovarian tissue develops normally, but until the 3rd month of gestations, but thereafter there is gonadal dysgenesis. The diagnosis of the Turner syndrome can be confirmed by karyotype analysis. Prenatally, a diagnosis of Turner syndrome usually is made incidentally after chorionic villus sampling or amniocentesis for unrelated reasons such as advanced maternal age. Prenatal ultrasound finding includes increased knuckle translucency. The postnatal diagnosis of Turner syndrome should be considered in female neonates or infants with lymphedema, knuckle folds, low hairline, or left-sided cardiac defects, and in girls with unexplained growth failure or pubertal delay. The diagnosis should be considered in all the women who presents with primary or secondary amenorrhea and elevated gonadotropin levels. Detailed cardiac or renal evaluation should be performed at the time of diagnosis. Management of Turner syndrome. The management of girls with Turner syndrome requires a multidisciplinary approach because of the number of potentially involved organ systems. Prophylactic gonadectomy is recommended for individuals with 45XO or 46XY mosaicism because there is an increased risk of gonadoblastoma. Now we come to the management. Adults with Turner syndrome require long-term estrogen replacement therapy and should be monitored periodically for the development of aortic root dilatation, hearing loss, and the other somatic complications. Long-term follow-up of the woman with Turner syndrome involves careful surveillance of the sex hormone replacement and reproductive function, bone mineralization, cardiac functions, and aortic root dimensions, blood pressure, weight and glucose tolerance, hepatic and lipid profiles, thyroid function, and hearing. The complications consist of individuals with congenital heart defects are associated with increased risk of aortic dissection. Individuals found to have congenital renal and urinary tract malformations, 30% are at a risk of urinary tract infections, hypertension, and nephrocalcinosis. So this was all about Turner syndrome. In the next lecture, we are going to discuss about more genetic disorders. This session was powered by Digital Version 2.0 JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow.